Good morning. I'm Dr. Lavanya, Associate Professor in Department of Anesthesiology at Sri Lakshminarayan Institute of Medical Sciences, Pondicherry. Today we are going to discuss about the topic supraglottic airway devices. So in this class we are going to discuss about the definition, the classification of the supraglottic airway devices, basic LMA, its description, available sizes, how to insert it, what to check prior to the insertion, and the signs of correct placement, the problems associated with it, the indications and contraindications, simultaneously the advantages and disadvantages. So, what is a supraglottic airway device? These are the devices that are used to maintain the airway patency and provide ventilation by placing just above the glottic opening. So that to maintain the patency of the airway in difficult situations. Standard of airway management, filling the Nike between face masks and the tracheal tubes. So it is the instrument where we use, it falls in between the face mask and the tracheal tubes. So it is like a bridging the device between face mask and the endotracheal intubations. So they sit outside the trachea and provide a hands-free means of airtight airway, gas-tight airway. That means it is air sealed. There is no leakage, and it is sitting outside the trachea. So the first commercially available supraglottic airway device was classic LMA, which was introduced in 1989. So their classification is based on first generation. So it is first generation, second generation, third generation. So the first generation is a simple airway device, and the second generation is designed for its safety, whereas the third generation is a self-sealing cuff and self-engineered technique. So the first generation will have a low pressure pharyngeal seal, whereas the second generation will have high pressure pharyngeal seal, and the third generation will have a combination of bite block and the esophageal drains. So the first generation may or may not protect from aspiration. So this is a limitation in the first generation, whereas in the second generation, there is a reduced risk of aspiration. And in the third generation tubes, it is totally, 99% is preventable. And in the first generation, they have no specific design to lessen the risk. In second generation, may be more efficacious in ventilation because it is a self-designed, specially designed for its safety. The most common examples for first generation will be the classic LMA and the flexometallic LMA, flexible LMA. And in the second generation is the ProSeal LMA, Supreme LMA, iGel, and the Slip-On. And in the third generation, it is the Basca mask and the Elisha. We are going to learn about the classic LMA. So, based on the sealing mechanism, they are classified as cuffed perilaryngeal sealer, non-directional, non-esophageal sealers, which include the classic LMA, flexible LMA, and LMA unit. In directional non-esophageal sealing, it includes the fast track LMA. Directional esophageal sealing is ProSeal LMA and Supreme LMA. Whereas in the cuffed pharyngeal sealers, it is without esophageal sealing. That is the example of COPA, which is cuffed oropharyngeal airway, and the PACS. Slowly we'll learn about all these. With esophageal sealing, it is the combi tube and the laryngeal tube and the laryngeal tube sections. With the cuffless pre-shaped sealers is with esophageal sealing, it is the Basca mask and the iGel. Without the esophageal sealing, it is the slipper or air tube. So based on the number of lumen, it is single lumen tubes, and double lumen tubes, and triple lumen tubes. Single human tubes, the classic LMA, LMA unique, LMA flexible, ILMA, C-track, soft seal, laryngeal airway device, AMBO, laryngeal mask, pharyngeal airway express, Cobra, perilaryngeal airway, laryngeal tube, cuffed oropharyngeal airway, streamlined liner of the pharyngeal airway, glottic aperture seal devices. These are all comes under in the single human devices. Whereas in double human devices, it is the ProSeal LMA, combi tube, laryngeal tube suction, and airway management device. Whereas pure laryngeal tube will come in the single human device. And in the triple human devices, it is the Elisha airway device. He is the one, he is Dr. Archie Brain, who first who first introduced the classic element, where he has used in Goldman dental mask with endotracheal tube. So these are all the Goldman mask cuff attached to 10 plastic tube with the basis of element prototypes. Now there are research have been done and so much LMS, advanced LMS, self-engineered, self-sealed, um, pre-shaped LMS, everything are introduced now. So what are the advantages and disadvantages when compared to face mask with the use of LMS? The advantages, they are more secure, reliable means of ventilation and reduces the risk of aspiration, and the hands of anesthetist are not preoccupied. Whereas in the disadvantages, it is the post-op sore throat does not ensure absolute protection against aspiration. So this is the LMA Classic, where it contains a 15 connector, an airway tube with a cuff with apertures inside it, and there is a small tube coming out that is called inflation line with an inflation pilot balloon valve. So that is the curved tube and elliptical spoon-shaped mask. The shaft and cup are connected at an angle of 30 degrees. The two flexible vertical bars prevent obstruction of tube by epiglottis. Inflatable cuff surrounds inner rim of mask. Inflation tube and self-healing pilot balloon proximal wider end of mask. Machine end of the tube as having 15 connector. And the seal pressure is usually 25 centimeters of water. And it is made up of silicone, which is latex free. These are the different available sizes of it. These are the available classic LMS. It ranges from 1 to 6. Mask size ranges from 1 to 6, and it can be used from neonates to adults. And the appropriate cuff pressure is given inside that. So mask size 1, which is used for neonates or infants up to 5 kgs, and the maximum volume inflation goes to 4 ml. And the mask size 1.5, where we can use for infants up to 10 kgs, can be, and the volume will be 7 ml. And mask size 2, where it can be used in children up to 20 kgs, the volume inflation will be 10 ml. In 2.5 size, it is children up to 30 kgs, and the inflation is about 15 ml. And it's a mask size 3, the children weighing less than 50 kgs, and the volume of inflation will be around 20 ml. Whereas in the mask size 4, it is coming to adults weighing around 50 to 70 kgs, and the volume is 30 ml. And mass size of 5 is 70 to 100 kgs adults. Inflation volume will be 40 ml. Mass size 6, it will be larger adults which are weighing more than 100 kgs, and the volume inflation will goes to 50 ml. So preparation prior to insertion. Select the proper size of LMA. Inspect the LMA for any tear or blockage. Slowly deflate the cuff to form a smooth, flat, wedge-shaped cuff, a wedge-shaped opening. Overinflate, look for any leak. Use a water-soluble lubricant to lubricate the posterior surface of LMA just prior to insertion. Avoid excessive amounts of lubricant on the anterior surface of the cuff or in the ball of the mask. So insertion technique, how to insert the classic element. The position of the neck should be flexed and the head should be extended. Use of non-inserting hand to stabilize the occiput. Jaw should be pulled down by an assistant. Element tube grasped like a pen with index finger pressing the point where the tube joins the mask. Place the tip of the LMA against the inner surface of the patient's upper teeth. Aperture facing forward, the tip pressed upwards against the hard palate. Mask is advanced into the pharynx to ensure that tip remains flattened and avoids the tongue. So these are the crucial steps for the insertion of the LMA. The neck is kept flexed and head extended. Press the mask into posterior pharyngeal wall using the index finger. Continue pushing with your index finger and the guide the mask downwards into its position. Grasp the tube firmly with the other hand and then withdraw your index finger from the pharynx. Press gently downwards with your other hand and ensure the mask is fully inserted. Inflate the mask with recommended volume of air. Don't overinflate the LMA. Normally, the mask should be allowed to rise up slightly out of the hypopharynx and as it is inflated to find its correct position. Insert a bite block or roll of gauze to prevent occlusion of the tube. Now the LMA can be secured utilizing the same techniques as those employed in the securing of an endotracheal tube. There are other techniques which are called 180-degree technique, partial inflation technique, thumb insertion technique. The signs of correct placement, how you will find. The slight outward movement of the tube upon the LMA inflation, the presence of a smooth oval swelling in the neck around the thyroid and cricoid area, and no cuff visible in the oral cavity. Ventilate the patient while confirming equal breath sounds over all the lung fields and absence of ventilatory sounds over the epigastrium. The parts of LMA and their position. The distal tip of the silicone cuff should be at the upper esophageal sphincter, and the sides of the cuff should be in the piriform fossa, and the upper part of the cuff should be at the base of the tongue. Failure to press the deflated mask up against the hard palate or inadequate lubrication or deflation can cause the mask tip to fold back on itself. The first figure it is showing. So once the mask tip has started to fold over, this may progress, pushing the epiglottis into its down-folded position, causing mechanical obstruction. In the second figure, if the mask tip is deflated forward, it can push down the epiglottis, causing obstruction. So the own of epiglottis may obstruct it. If the mask is inadequately deflated, it may either push down the epiglottis or enter the glottis. Now this is the LMA unit. It is also almost the same, but it is latex free. It is designed for single use, made up of polyvinyl chloride, and it is cheaper. This tube is stiffer, cuffless compliant, less rise of intracuff pressure with nitrous oxide. More difficult to insert. Same sizes will be same as the classic LMA, and the pressure also ranges from 40 to 60 centimeters of water. This is the flexible LMA. It is also called reinforced tube. Length of the airway tube is longer and diameter is smaller as compared to the classic LMA. Tube will be longer and the diameter will be little smaller when compared to the classic LMA. The length and flexibility makes it easier to move away from the surgical area. More resistant to kinking and suitable for head and neck surgeries. Cuff sizes will be same as the classic LMA and it is more difficult to insert since it doesn't have a stiffness in the body. It is more difficult to insert and the pressure ranges from say, 40 to 60 centimeters of water. This is the LMA fast track where you have an epiglottic elevating bar with attached to the cuff, the airway tube, and there will be a handle to handle it. So this fast track is short and wide board shaft that follows the anatomical curve of the palate and posterior pharyngeal wall. An epiglottic elevator bar at the mask aperture. It is an armored flexible endotracheal tube with a longitudinal and a horizontal black line that coincides with the epiglottic elevating bar. Inflate cuff as per manufacturer's recommendation so that intra-cuff pressure does not exceed more than 60 centimeters of water. This is having different sizes according to the body weight. For 30 to 50 kgs, ILMA size 3 and the volume inflation will be 20 ml and the tracheal tube which we can insert is 7 ml. But for 50 to 70 kgs body weight, the ILMA size will be 4 and the air volume will be 30 ml and the tracheal tube will be 7.5 ml. The body weight who is ranging from 70 to 100 kgs, ILMA size will be 5 and the air volume will be 40 ml and the tracheal tube insertion is 8 ml. They increase the seal pressure and aligns the axis of trachea and the endotracheal tube. First step, rotating the ILMA in coronal and sagittal plane in an attempt to find the least resistant ventilation position. Second step, it is to grasp the handle and use it to draw LMA forward 2 to 5 mm in a lifting action without levering the teeth. So what are the advantages and disadvantages? Advantages, it is useful in cannot intubate, cannot ventilate scenarios. Allows fast insertion into correct position without moving patient's head or neck. Can be used alone or as a guide to intubation. Facilitates ventilation between ILMA insertion and endotracheal tube insertion. It is a good conduit for fibro-optic intubation in presence of blood or clot in oral cavity. Whereas the disadvantages follows, it's most likely to dislodge in head or neck manipulations, unstable for MRI, unsuitable, difficulty in insertion with limited mouth opening. On removal of LMA, tracheal tube can be displaced downwards. So this is the LMA C track. It is almost similar to the ILMA in construction. Two built-in fiber optic channels, one to convey light, other to convey the image to the viewer. They emerge under epiglottic elevating bars, which lift the epiglottic as tube passes. Fiber optic system is sealed and it can be autoclaved. Monitor is attached via a magnetic latch connector. So it is inserted exactly as the LMA fast track. Once the airway is secured and the patient is being ventilated, the viewer is switched on, placed in the magnetic connector, and the clear image of the larynx is displayed in real time on the screen. The endotracheal tube can be viewed as it enters the trachea. Once the patient is intubated, the viewer is removed and the mask is removed, leaving the endotracheal tube in place. The problems, it has a poor image quality than a flexible fiber optic endoscope. It cannot be used easily in the patient with a very limited mouth opening. The view may be obstructed by secretions, lubricants, or sometimes blood. So this can be reusable, silicone made, and most specialized modification of classic element. This softer and revised cuff arranged dorsal, that is the dorsal cuff, is responsible for the higher seal pressure and higher seal pressure of 30 centimeters of water for the LMA Pro Seal. The four main components of this tube will be the cuff, inflation line with pilot balloon, airway tube, and the drain. Modifications includes the esophageal drain tube, posterior inflatable cuff, reinforced airway tube, integral bite block. Single use, it is made up of polyvinyl chloride and has features just like Prosil LMA, intubating LMA, and the LMA unit. It is used for single use, large inflatable plastic cuffs with no posterior cuffs, esophageal drain tube, preformed semi-rigid tube, fins in the mask bowl to prevent epiglottic obstruction. Pharyngeal seal is intermediate between a classic LMA and the Prosil LMA, and the cuff pressure is around 20 to 30 centimeters of water. This is the laryngeal tube, where the cuff pressure is 60 centimeters of water, and there are four types of it: laryngeal tube, LTD, LTS2, LTSD. It is also a latex-free and single-use, single patient use. It can be orientation can be seen in the X-rays. It has a single valve pilot balloon, which inflates both the proximal and the distal cuff. And it is marked with centimeters so that you can know the depth of the how deeper it is inside there. Proximal cuff stabilizes him and seals the oropharynx. Bilateral eyelets to supplement ventilation, and the distal cuff blocks the entry of esophagus, reduces the possibility of gastric inflation. So the two ventilation outlets in front of the larynx for efficient ventilation and allows the passage of fiber optic bronchoscope or the tube exchange catheter. This is the Cobra. It is also a single-use PVC made latex tray, has a breathing tube with a larger inner diameter with to increase airflow. Novel head design, like a Cobra, head of a Cobra. Bars allow ventilation and instrumentation. Cuff pressure is less than 25 centimeters of water. Proximal high volume, low pressure cuff seals hypopharynx. Offers a more effective seal and a better fiber optic score as a classic element. So the novel supraglottic airway devices designed by UK anesthetist Nazare. It is the single-use, cuffless, made of soft polymer and is shaped similarly to an inflated element posteriorly with its anterior shape designed to fit into the perilaryngeal structures. Narrow bore esophageal drain tube, short wide bore airway tubes, integral bite blocks, and epiglottic rest reduces the possibility of epiglottis downfolding and airway obstruction. The pressure in the eye gel should be 40 centimeters of water. These are the different sizes of the eye gel and the patients and their weight according to their weight. 2 to 5 kgs, it is neonates, eye gel size 1. 5 to 12 kgs, it is infants, eye gel size will be 1.5. 10 to 25 kgs, children's size of 2. 25 to 35, larger children, little younger children, that is 2.5 size is used. 30 to 60 kgs, adults, 3 size. 50 to 90 kgs, medium adults, which are size is 4, and more than 90 plus kgs, it is big giant adults, which are larger size of 5 is used. This is the this is the eye gel which is showing There is a bite block and the reservoir attachment. There is an attachment to the suction, and there is a cap for manually curving the mask for easy insertion. It is a self-sealing membrane of extraglottic airway device using a sump and two gastric drains. So the So the ball of LMA closing fast track AQ is large, Busca is small. A tab of Busca mask which can increase its angulation for easy negotiation. Busca mask by adding a second gastric channel which is left open to ambient atmosphere nearly equilibrate the pressure in the sump cavity to atmosphere. So Busca mask is a cuffless device with a membranous ball which inflates with each positive pressure and then deflates to atmospheric levels during passive expiration. Enlargement of the size of gastric channel opening by its fish mouth type in Busca mask. This is the Busca mask airway. It is having different parts which are marked from A to I. A is the mask, B is the airway, C is the gastric access channel, and D is the four-way connector, and E is the inflation line, F is the inflation pilot balloon, G is the check valve, H is the ET tube guide device, I is the dorsal cuff. These are all the uh, some of the users you can see. There will be a good of the supraglottic airway devices. There will be a good seal and long-term ventilation. The design of ventilation mask conforms to dorsal cuff and can help in achieving good seal and long-term ventilation. Easy to insert and fix. The curve of the block of the tube is designed for rapid blind insertion. Four-way connector makes it easy to fix after placement. The four-way connector makes it easy to fix after placement with the help of a strap provided. Integrated bite block prevents airway occlusion. The design of the bite block can prevent the tube from being thickened. The sputum collection device can collect a small quantity of sputum secreted. The design of inlet and outlet gastric access channel is easy for gastric tube insertion. And the airway tube more than 95 degrees angulated short airway tubes provides easy insertion. This is the LMA gastro airway, which is proactive airway management for endoscopy procedures. Benefits. It inspires confidence by supporting end-tidal CO2 monitoring and direct endoscopic access. Institution designed to help reduce airway-related complications during endoscopy procedures. Patient silicone cuff and integrated cuff pressure monitoring for the patient comfort, separate gastric and elbow access designed to support patient safety, integrated cuff pilot technology. With the gastro airway, which has all those endoscopic channels, adjustable holder and strap, integrated bite block, and cuff pilot. That is the cuff pilot technology. The silicone airway tube and cuff. This is the protector airway. The multi-purpose single-use laryngeal mask features a 100% silicone airway tube and cuff with a dynamic curve that confers the contours and the anatomy, allowing for rapid insertion and secure fit in both routine and unexpected difficult airway situations. Its unique combination of innovative capabilities are designed to help clinicians to reduce the risk of airway-related complications and improve patient outcomes. Dual gastric access, effective gastric access is considered to be an important in advanced uses where gastric content is unknown and there is an increased risk of regurgitation. LMA protector airway features a proprietary dual gastric drainage channel and suction ports combined with a high capacity gastric chamber, allowing for suction and decompression of the stomach via gastric tube while providing exit channels for gastric contents in the event of regurgitation. This is the video of LMA, two early examples of a true third generation comprehensive multifunctional supraglottic airway device incorporating most of the features of second generation SADs with an additional lockable a videoscopy which can be unclipped after successful insertion. Simple and routine insertion like any other recipe but visualized insertion across the airway, fine control maneuvers if malposition is detected, secure optimal gas exchange instead of acceptance of good enough or best achievable, reduction in the extra space needed and increased complexity to the operator where the video laryngoscope is inserted into the oropharynx external to an supraglottic airway device, avoidance of damage to the crowded airways, intubation through the supraglottic airway device of a under direct vision, recording facility into the patient anesthesia record of correct placement of the supraglottic airway device. There will be a reuse of the videoscope of the device. This is the name of the supraglottic airway device and the ceiling pressure required. For classic LMA, it is 20. For LMA ProSeal, it is 30. iGel, it is almost 30. For laryngeal tube, it will be 13. Combi tube, it is 35. Easy tube, it is almost 14. Slipper, it is 35. AQ, it is 13. Ambo, it is 25. LMA Supreme, it will be 30. What are the indications of LMA? Alternative airway during GA, especially in short surgical procedures and minor therapeutic or the diagnostic procedures like radiation therapy, diagnostic and interventional radiology, endoscopy, etc. Cardiopulmonary resuscitation to secure the airway, essential part of the difficult airway problem, and it is relative indication in professional singers to avoid vocal cord trauma. What are the contraindications of LMA? Limited mouth opening, less than 2 fingers, local pathology in pharynx, larynx, or upper airway, trismus, facial or upper airway trauma, increased in risk of aspiration, morbid obese, delayed gastric emptying, acute abdominal or thoracic injury, history of any reflex disease, and hiatus hernia, reduced lung compliance or increase of work of breathing. What are the advantages and disadvantages? Advantages, it increased speed and ease of placement, less requirement of expertise. It has an improved hemodynamic stability at induction and during emergence of anesthesia. There will be minimal intraocular pressure or intracranial pressure changes during insertion of this tube. There will be increased airway tolerance. There will be lower frequency of coughing during emergence and improved oxygen saturation during emergence. So what are the disadvantages of SIDCs? There will be an inadequate positive pressure ventilation. Sometimes there will be inadequate if the lung is huge and the size and there is inappropriate between the size and the patient volume. There will be inadequate positive pressure ventilation. Whatever the required tidal volume, we are not able to generate in the patient's lung. So more chances of aspiration of the gastric contents. So there will be tight sealed over the epiglottis, but since it is not placed inside the trachea, it is just above the trachea and it has a tight seal. There will be a minute chances of aspiration of aspiration of the gastric contents. Patients may develop sore throat post-operatively, and there may be compression of the vascular structure surrounding the cuff due to continuous pressure over the vascular structures, and there may be compression over the nerves also, and may lead to nerve damages. Thank you. So these are all the techniques these are all the different LMAs which are used and what is the difference, how to insert, when to insert, where to insert, and advantages and disadvantages, their classification, advantages, how they have been gradually took modifications, from the classic element to the advanced Alicia Airway devices or the SLIPA, gel, etc. So based on the different generations, you have to know all the differences between classic LMA, Procil LMA, iGel, Busca mask, laryngeal tubes, laryngeal airway exchangers, slip arm. Each one is modified accordingly. Um, so you have to know about each and everything, their structure and their modifications, how they have been modified and what are its uses, how what are the advantages and disadvantages, why there is a transformation from first generation to third generation, what are the advantages over first generation in third generation supraglottic airway devices. So these are all the take home messages what to do in this topic. So you just watch video regarding how to insert the element and so that you will have an clear view how to insert it. So any doubts in this topic, you can please raise a query. We can discuss over that. Queries. Okay then. Next class you will have, we are going to discuss about coagulation and anesthesia for second years. And for final years, it is case discussion about mitral stenosis, pregnancy, and mitral stenosis. Okay. Thank you so much.